and also produce parastomach hernia. And so I always remove through fancy incision.
Yeah, parastomach hernia, before that we will close it. The problem is what I have found, in a thin female patient I try to remove, because even for this fellow, he is a young fellow but very strong musculature. Even putting the trocar is very difficult. I know if you try to remove, then there will be a while till we make the pouch, then edema of the small bowel mesentery will be there and difficult to put it inside also. So
Yes.
I prefer to take, particularly in all male patients, phalangeal incision and make the pouch. Then you create separate ileostomy. In a thin female patient, as I said, if it is obese female, it's the same thing. If it is a thin female patient, it is now a lot of yielding of the muscle is there. Then we'll try. But still, it should be very cautious. We may have to put little bit bigger incision, then close it. Anyway, we will be closing this in 6 weeks time. Ileostomy reversal. The advantage is you can just make this midline incision as above as possible. Bipolar, bipolar kuda.
So people do practice removing the specimen through the ileostomy site, but my experience is better to remove through the fan steel.
Bipolar கால் கிட்ட வைங்க. இங்கமா இருக்கு இருக்கா. கை கிட்ட கிட்ட தான்.
Rajapandian.
Yes, yes.
So regarding removal of specimen through the ileostomy, so even though it leads to paroxysmal hernia, which you mentioned that you will close the ileostomy as soon as possible, but
Yes.
my and the study shows that any incision in the abdominal wall can produce incision hernia even after you close this one, because your length of incision is longer. So phalangeal is only incision where the incision hernia is minimal when compared to
Very.
the other
Yes, yes.
areas of incision.
Yes, yes, I understand.
And also, what I have found in my practice is I had two cases of volvulus of the small bowel, which I think that because we have done everything through the ileostomy site and there is no
Yeah.
adhesion, so the small bowel is free to rotate, and it formed two cases which formed volvulus. So I said I will remove the specimen through the fan and steel, so at least there will be a little bit of adhesions will form to prevent the volvulus. Those are the reasons why I don't remove it through the ileostomy site. And also, we are dealing with patients with BMI more than 30 most of the time.
Yes, yes. It is better to remove through the financial incision.
And tell me about the phalangeal incision. Where do you make? How do you make? Do you make a flap above and below, or do you cut the muscles, or you open the midline?
I
I'm
think
saying
everybody is seeing. So far, I am making the flap above, lower flap small. You have made. You can see up to the perineum muscle. So lower flap also you have to make, but not up to the, because below if you go make more, then the bladder will be there while opening it. So the initially many people when the PGs they would have opened the bladder, because it will
yes.
be just at the level of the bladder we have put the trocar, 10 mm trocar. We have removed that 10 mm trocar, and I have just doing that. So the upper flap you can make maximum, so that there will not be any tension while taking this thing. Okay. Yes, Punanga?
I also believe that if you make a lower flap, the blood supply to the lower flap is not good. So it is better to make upper flap
Yes.
and also avoid bladder injury. Then do you cut the muscle or go in the middle?
No, no, middle only.
Middle.
Always middle. Will not cut the muscle.
So better to go in the middle so that you don't have to weaken the muscles. And do you keep the pneumoperitoneum to help you, or the pneuma is gone?
Always, always I have started the Nemo. So Nemo will help to identify the peritoneum. Hold this. So that is the advantage. While even doing the ileostomy also use the pneumoperitoneum.
Yes.
So that is the advantage. So without injuring the small bowel, we will create. So this lower flap should be, we are very close to the bladder, should not open the bladder.
Have you opened the bladder before?
Sorry,
Have
myself.
you opened the bladder before?
Yeah, one of my PG has opened, then I have to close it. Yes.
Close the bladder. Yeah, fine.
Yeah. That is not a big thing.
Yeah.
You open, close
And
it,
what
and
kind of wound protector you are going to use here?
sorry,
Wound
wound
protector.
protector. Just I will show you. Man, the இது எடுத்துக்கோமா. Cut.
Is it a gem made one?
Yeah, Gen made only.
Not the Alexis wound protector.
So there are so many wound protector. Anyway, there is no need for wound protector for this case. We are not having a full malignancy. இல்லைம்மா இதை கொடுமா ரொட்டீன் தான் இது என்ன சின்னதாக இருக்கு கொஞ்சம் பெருசாக போடு அது அதை கொடு So routinely we use that அது நல்லா இல்லை ஒன்றுக்கு ரெண்டுக்கு இடையில இருக்கு This is our specimen bag. We just opened it.
Yeah.
We just keep for wound protection.
So now how we are going to close this wound for the rest of the surgery? So
No, I will be just next. I will be just closing it with the. இது கொடுமா
now you can see the specimen coming out.
ஹெட் அப் கொஞ்சம் பண்ணிக்கோங்க
Why you are doing head up? To bring the specimen down.
Yeah. No, okay. There should not be much traction to the specimen. Little bit head up. Bring all the momentum. Yes. Whole specimen has come.
Yes.
Keep in anatomical position in such a way that there will be any twist in the. Okay. Twisting should not be there. Keep like this. No, clamp. You can see the vessels clearly.
Okay.
In this case. Clamp. So I am just going to divide with the clamp.
Okay.
Then I will put one this thing. Whether we can do that. Nice blood supply is there.
So you can feel the blood supply. You don't need to do an ICG check or anything.
Yeah, no need to do anything. So I am planning to clamp ஒரு சில்க் எடுத்துக்கோ இல்லாட்டினா இப்படியே பிடிச்சி இதே போட்டுடலாம் சார் இது கொடுத்துரு white stapler. So I am going to divide with the white stapler itself so that not be any problem for me. Otherwise I will put a clamp, then I will put a silk, then after making the pouch at the end I will be doing that. அது மாதிரி கூட பண்ணலாம் கூட கிளாம்ப் கூட சில்க் எடுத்துக்கோ இன்னொரு கிளாம்ப் கூட இல்லை இது எப்படி பிடிச்சிக்கோ Sister, specimen out.
Very good specimen, Rajapandian.
Yeah, yeah. Just show the specimen or silk kuda. So I'm just going to have a silk with this. Then at the end I will be dividing with a stapler. அதெல்லாம் எடுத்துரு எடுத்துரு.
So you're going to make the pouch now.
Yeah.
Do any assessments whether this will come down to the pelvis? What are the things you will do to make sure the pouch will reach the lower rectum?
First thing is in the laparoscopic, first itself, once the bowel is coming, எடுத்துரு. See, bowel is coming freely to the எடுத்துரு. If it's coming to the pelvis, then there is no problem at all for you. Anyway, then we have divided the DJ flexor relaxation incision, Kuduma. Then we have taken the ileocholic artery at its origin. Another thing is you make the pouch gone beyond the pubic symphysis without any problem, then we can இது எடுத்து விட்டுறலாம். டேபிள் ஹைட்டு கொஞ்சம் இன்க்ரீஸ் பண்ணு. So I am going to have a 12 to 15 centimeter pouch.
Okay. You are going to measure it now.
Yeah. நான் ஒரு இது 15 சென்டிமீட்டர் இது பவுச் எடுத்துக்கோ. பட் ரஃப்லி ஓகே போதும். So I will be firing 360 mm, that is 6 centimeter. So it will like 18, instead of 18 it will come 15. So like this. Okay. இது கொடுமா, இது எடுத்துடலாம். சிசர் கொடு, சிசர் ஸ்ட்ரைட் சிசர் கட் பண்ணுறதுக்கு அதையும் எடுத்துரு. இந்த இதெல்லாம் எடுத்து விட நிற்கிறதுக்கே கரெக்டாக இல்லை எனக்கு, இப்படி இருக்கு. You can see easily it is coming beyond the pubic symphysis.
Yes.
So these are the indirect measurement.
Okay? Yes.
But still, if it not coming, then we may have to use some relaxation incision after going inside. Okay.
Okay.
But before that, I want to make sure all the bowel is coming on the other way. There is so much of twist in this patient right from the beginning. Put a retractor. Okay. கொஞ்சம் இது மசாஜ் பண்ணிட்டியா? ரெண்டு இது கொடு.
Back happen, sir.
ಬ್ಯಾಕ್ ಹಾಕ್ಬಿಡು. ಸ್ಕೇಲ್ ಇದು ಗೊತ್ತಿಯಾ ಕಾಮಿ ಮಿಸ್ಟರ್? So you can have exactly 15 centimeter.
Yes, we can see.
Okay. So this will be my pouch. Okay. Stitch ಕೊಡು. So I will make one purse string.
First string.
Use it even without we can just make a ಕುಡ್ಕ್ರಿಯಾ ಸಕ್ಷನ್ ಹಚ್ಚಿಕೋ.
It's better to do whatever you practice and what you are doing. Hmm?
Yes, yes, yes. This is more crucial actually.
Yes. Hmm.
அதெல்லாம் இப்போ பிடிச்சிக்கோங்க. அதெல்லாம் போடாது போடாது போடாது. இது வந்து கொஞ்சம் இதாக விட்டுரு, நீ விட்டுரு, ரிலாக்ஸாக தான் இருக்கு.
So the stapler for the pouch creation will be done through the genu or from the end, sir? You're taking a purse string right now.
Yeah, where I'm taking from the apex.
From the apex, you'll be firing the stapler.
Yes.
So in that case, why this end has been tied with a suture? Why is it not stapled?
I will show you at the end.
Okay.
Because we don't want that extra whatever is there. That's why I kept. As you said, we can do a stapler at the end as well.
Okay.
Sometimes the anvil doesn't go in this area, then we need to open that and we'll take that. Raitarmi. எடுத்துக்கோ, ஒயிட் ஸ்டேப்லர் எடுத்துக்கோங்க, சக்ஷன் எடுத்துக்கோ. கவுட் எடுத்துக்கோ, லாங் கவுட். கொடு. So I'm taking a white stapler, 60.
Okay.
ரெண்டு கீழே பிடிச்சி எடுத்துக்கோமா. அப்படியே பிடிச்சிக்கோ. அப்படியே பிடிச்சிக்கோ. ஓகே, ரொம்ப போய்க்கும். வெயிட் ஃபார் 1 minute. இங்கே பிடிச்சிக்கோ ரெண்டு பக்கம். இதை பிடிச்சி. ஓகே, 1 minute ஆயிடுச்சா? ரெண்டு பக்கம் பிடிச்சிக்கோ. ஆயிடுச்சா? So wait for 30 seconds or 1 minute so that the interstitial fluid will go. Okay. அச்சா மா அட்ரினல் சோப் காஸ் வச்சுக்கோ. ஒரு ட்ராப் போட்டு 20 ml சலைனில் அட்ரினல் போட்டு சோப் பண்ணிவிட்டு ஆட்டக்கூடாது. சர்க்குலர் ஸ்டெப் சத்தியமூர்த்தி இருந்தால் வர சொல்லிடு. சத்தியமூர்த்தி ஆர் ஹரீஷ். யார் இருக்கா ஓபியிலிருந்து? ஆஸ்க் சத்தியமூர்த்தி ஆர் ஹரீஷ் டு கம் ஃபார் சர்க்குலர் ஸ்டெப். अच्छा हाँ ये लूज कर. Okay. Tab on tooth forces. Gas piece. Usually adrenal soak, saline soak gas I will use. Each firing you just look for any bleeding is there.
Okay.
Victorian இல்லைம்மா, சலைன் சோப் இல்லைம்மா, பில்டான் கிடையாது. அட்ரினல் சோக் காஸ் பீஸ் கொடு. ட்ரை காஸ் இல்லாட்டினா கொடு. சின்ன காஸ் பீஸ் கொடுக்கணும்.
Do you routinely do it or only if you find some bleeding?
No, routinely we just will put so that we'll have the patency of the lumen.
Okay.
ட்ரை காஸ் சின்னது கொடுமா. அம்மா அதில் பாதி பண்ணி கொடுங்கம்மா. சரி இதை கொடு, இதில் பாதி கொடு, அதை கொடு. சின்னது பண்ணி இப்படி கொடுத்து உள்ளே போகாதுல்ல. இதே சலைனில் அப்படி சோக்கி முக்கி சின்னது பண்ணி ட்ரை பண்ணி கொடுக்கும். அந்த சலைன் சோக்கு அதில் போட்டு விட்டு ஒரு ஒன் ட்ராப் அட்ரினலின் 20 ml சலைன். ஓகே, அது ப்ளீடிங் இருக்கு பாரு. சார் அந்த இது கொடுத்துரு. இன்னொன்று ஸ்டேப்லர் கூட சீக்கிரம் அது வரும்போது எடுத்துரு. க்ளோஸ் வந்துச்சுன்னா பிடிச்சிக்கோ. எடுத்துரு. அப்படியே பிடிச்சிக்கோ.
Any specific tips for firing the second stapler, sir? Particularly.
Yeah, second stapler. Yeah. So we should know that this is there is a gap will be there.
Yeah.
So because it is a endo-GA stapler, you don't close it. Halfway you go inside and you will know where it is there, where it has to be. Then
Okay.
as open on each limb, you have to go inside. So that's why you have to palpate and do. The first is crucial. After that, it will be easy. First is only you have to take each limb of that ilium from the apex. The only problem is there may be ooze from the bleeding from the pouch formation from the staple side. That's why you are using white. So initially I was using blue, but in a thicker bowl I used to use blue. But thin. ரெண்டு பக்கம் பிடிங்க. இது பிடிச்சிக்கிட்டே இருக்கணும். அது இருக்கணும். அதை பிடிச்சி இங்கே ஒருத்தர் பிடிமா, இந்த ஷேக் ஆகக்கூடாது. இது எப்பயும் இழுத்து பிடிச்சிருக்கணும், ஃபயர் ஆகும் போது.
I think Rajpandian, what you made your assistant do now is very important step.
நான் டூத் ஃபர்ஸ்ட் கொடு, இல்லாட்டினா வேற மாதிரி ஃபயர் ஆகும். இப்போ அந்த இது கொடு, செக்ஷன் கொடு. காஸ் பீஸ் கொடுங்க. Now the gas piece will go freely. நீ சும்மா இருக்கும்போது காஸ் பீஸ் கட் பண்ணி கரெக்டாக வை. சலைன் வச்சுட்டிங்களா? முக் பண்ணி சலைனில் முக் பண்ணி ட்ரை பண்ணி கொடு. 2-3 போட்டு வச்சுக்கோ. அடுத்து ஃபயர் பண்ணோன்னே உடனே ரெடியாக இருக்கணும். கொடு, புளிஞ்சு கொடு. ரொம்பவும் புளியக்கூடாது, கொஞ்சமாக புளிஞ்சு கொடு. ஃபோர்ஸப்ஸ் எங்க? ஆட ஸ்ட்ரெயிட்மா, கர்வ்டு ஆர்டரி ஃபோர்ஸப்ஸ். கர்வ்டு ஆர்டரி ஃபோர்ஸஸ். சரி பரவாயில்ல. பிடி இருந்ததா? 2 த்ரெட்டை பிடிச்சிக்கோ. See, this is adrenaline soak, 1 in 10,000. I have put 1 drop and 20 ml of saline. Dry gas kudu. Sir. Dry gas one kudu. Kudu open பண்ணு. அது குடு. அம்மா இங்க பாரு, இப்படி முடிச்சு கொடுமா. இப்போ saline லூஸ் விடு. அட்ரினல் சோக் சலைன் வந்து நெக்ஸ்ட் டைம் வந்து கொஞ்சம் அப்படியே இது 2 பக்கம் கொடுங்க. சோக் பண்ணி புளியாமையே கொடுங்க. இன்னொரு ட்ரை காசு கொடு. சலைன் சோப் இது கொடுத்துரு. அட்ரினல் சலைன் போட்டுக்கோங்க. Okay, now it has become dry. Okay. Kudu அடுத்த ஃபை இது குடு. இந்த ரெண்டையும் சேர்த்து இப்படி பிடி. இந்த இடத்துல போடு. பேக் போடு. இந்த இடத்துல போடு. பொடி 2 கை இரு ஓப்பன் டைட் பண்ணாதம்மா, ஓப்பன் பண்ணி கொடுமா. இப்போ இழுத்துக்கோ. பேக் எடுத்துடு. விடு. சரி பிடிச்சிக்கோ. So this excess we will resect. So that is the aim.
Okay.
இப்படியே பிடிச்சிக்கோ. 2 பக்கம் பிடிச்சிக்கோமா. இதை பிடி.
So the adrenaline soak gauze, that step, Rajpandian, do you do it routinely, or did you have any particular problem this time?
No, routinely just I will do, because always there will be ooze, just to stop it. and make sure if it is more, then we can just avert and see whether we have to take a stitch or not. So that itself we can say the pouch is very much vascularized.
Yes.
We need not bother whether the vessels are there. Eh?
Yeah.
So much of blood is there while doing that. Eh? So the distal part, already there is a nice blood supply here. See, it is very pulsating. So this part I will then put another stapler to excise that.
And why is that? What happens if you leave it? Any particular problem?
Now not much problem will be there, but anyway it will be holding, it will act like a dormant one. Okay, va?
To avoid the blind loop, you're saying?
Yes, sir. Acha? Okay. True, true, true. இப்போ கொடு 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 காசு பீஸ் ட்ரை காசு கொடு சலைன் சோ காசு கொடு இல்லை ஸ்ட்ரைட்டில் இன்னொரு இது எடுத்துக்கோ சர்க்குலர் ஸ்டெப் போடுறதுக்கு வர சொல்லிடு கொஞ்சம் தான் இருக்குல்ல நீ அந்த இதை வச்சு போட்டு சும்மா கொஞ்சம் தான் இருக்கும் உள்ளே வச்சுட்டு மோட்டரைஸ்டு சும்மா இப்போ அந்த இதை பண்ணால் போதும் ஜஸ்ட் யூ ஹவ் டு ஓப்பன் பண்ண அதை பிடிக்காது இப்போ சர்க்குலர் ஸ்டெப் கொண்டு வந்திருக்காப்புல So not much of bleeding is there. So I am happy. Stapler எடுத்துக்கோ. So we have more than one more போடலாமா? சும்மா கொஞ்சமாக வச்சு போடலாம். கொடுமா. So I am planning to put one more. இது கூட அளந்து பார்க்கலாம் கூட. 12 centimeters enough. Okay. 15 is enough. Okay. வேண்டாம். It is stretchable, no? 15 centimeter மேலே இருக்கு. யாரு? சீக்கிரம் வர சொல்லு. இதை கூட இது கூட லிகாஷ் கூட இன்னொரு ஒயிட் கொடுத்துக்கோ. ஒயிட் கொடு. டூசரை பிடிஎஸ் எடுத்துக்கோ. பிடிச்சிக்கோ. அது எடுக்காமல் பண்ணிட்டுக்கலாமே. சரி, ஓகே, அது வழியே தான் போட்டோம். பர்பஸ் நாட் சால்வ். எடுத்துக்கலாமா? லாக் பண்ணிட்டேன். ஓகேவா? அன்பில் எடுத்துட்டியா? ஓப்பன் பண்ணுங்க சீக்கிரம். ரொட்டீன் 29 தான். 29 போடுறது கொஞ்சம் கஷ்டம் தான். இட் வில் நாட் கோ. ஓகே. ஸ்விட்சர் போட்டு கவுடு கொடு. சின்ன கவுடு கொடு. கிளாஸ் பீஸ் கொடு. க்ளீன் பண்ணுறது. அம்மா தெரியாதவங்களாம் பண்ண சொல்லாத. ஃபஸ்ட்டு டைம் பண்ணுறியா நீ சொல்லு. ஏன் இது இப்படி இருக்கு? பண்ணா யார்?
Rajpandian, and I think in the Chennai hospital they are starting another case. We'll just go across quickly and come back.
Yes. இது கொடுமா. ஜல்லி போடு.
On, sir.
Good afternoon, everyone.
Good afternoon, Chennai team.
So we're presenting the case capsule for the patient. The patient is a 66-year-old female who had come to us with constipation for the past 1 year, where she gives history of passing stools only after taking medication or laxatives. She also gives history of recurrent abdominal pain, left side and lower abdominal pain. Patient does not have any other comorbid illness, and she gives a past surgical history of hysterectomy done 30 years ago. Her general examination and abdominal examination were normal. Her rectal examination had a fissure at 6 o'clock. So we further evaluated the patient with a sigmoidoscopy, which revealed multiple diverticula, and there was also edematous mucosa with significant luminal narrowing of the sigmoid colon at about 25 centimeters from anal verge. Only pediatric scope could be negotiated through this area of narrowing. On CT imaging, we found few subcentimetric diverticula in the sigmoid colon with minimal perichoric fat standing, suggestive of diverticulitis, with minimal free fluid in the abdomen. So we can see the feature suggestive of sigmoid diverticulitis. So we have a patient with sigmoid diverticulitis with luminal narrowing who has been planned for laparoscopic sigmoidectomy. Thank you.
Hello.
Yes, hello, hi.
Yeah. Very good afternoon.
So good afternoon. I'm Dr. Mark Ranjan from CMC Vellore. With me is Dr.
Dr.
Murli
Murli.
from Kaveri Hospital, Hosur.
Very good afternoon. Good afternoon, Murli.
Good afternoon.
So what I have patient is a very obese patient with sigmoid diverticulitis with the inflammatory adhesions onto the lateral wall. Just put it here. Now I tried a little bit of a dissection onto the lateral wall. It looks inflammatory. So now I am proceeding to third. In obese patients, getting onto the plane into the mesocolon sometimes will be difficult. Patient is in steep Trendelenburg position. Still, even then, the intestines keep coming. We have kept large gastric packed so that we can, to some extent, I'm managing.
Okay.
It's not a big problem as we can see here. This acts as like a compound wall, so that maybe overflow will be there, but beyond this, it will act as a small barrier. This we have got it from the days of robotic surgery, so that we can plan. It's a small nuisance, but we can slowly come back. Find a way to address this issue. You can see the appendix. Obese patients are seen, externally you can see patient is obese, BMI more than 40, it's about 45. Yeah. Actually, so So even sigmoid diverticulitis can be tackled laparoscopically or robotic. Here we are planning for laparoscopic sigmoidectomy. ICG has been given. Now I will go slightly closer onto the sigmoid mesocolon. Now I will reposition myself. You can see a nice thick pericolic inflammation.
Yeah.
Okay, now let's put harmonic. I lift up here. Unless malignant one where we go to the root of the inferior mesenteric pedicle, here I restrict my division to the sigmoid vessels.
Yeah.
Yeah. Even the sigmoid mesentery is thick. Here, probably if there is a doubt, I might use the ICG mode. This is ICG overlay mode. You can see the right side urethra, can you see?
Yeah.
Yes.
Right side urethra is nicely seen. So we are safe.
Sadlan, I've got one question for you. We heard the imaging findings and the preoperative presentation. Any surprises intra-op, or are your findings consistent with what was seen on imaging?
One surprise was the lateral attachment to the bladder was not seen. Here I am expecting some attachment to the TME plane. Here I am entering the TME plane, this slightly low down, so that from there I can come up.
Okay.
I'm using a harmonic HC100. Here it has got a maximum and minimum mode which can coagulate and then divide vessels up to 7 millimeters. I'm expecting some inflammatory bleeding because sometimes there will be a lot of mesenteric adhesions, attachments. In the camera.
You'll be taking down the superior rectal artery also?
No, I'm not planning to take the superior rectal artery because my plan is to go to the sigmoid vessels, preserve the superior rectal artery, so that the vascularity of the
Distal stump.
yeah, it will be preserved. And we will also be giving a shot of ICG during the anastomosis, so that we will also come to know about the
Vascularity.
Yeah. This is a good indication for ICG based camera.
I think nowadays ICG is more used in colorectal surgery than in gallbladder surgeries, for which it was started.
Both are okay. I mean, as far as you can see the plane.
No, even in layer, it's more used for liver resections than in, I think, gallbladder surgery, I think. No, the utility wise.
Yeah. So now the superior rectal artery will be going here. I will not be dividing. I will be going slightly proximal, closer to the colon, sigmoid colon. So I'm using minimum mode. This minimum coagulation mode will cut up to 7 millimeter. It's a side button, it's not the front button. So you can see it seals off.
Is this a pro where you have extra that green button to cook extra?
Exactly, yeah, same pro, same pro. Now I'll go a little close to the, yeah, hold it like this. Slowly, we have to go slow in this inflamed tissue so that you avoid bleeding. One more in the bottom. Last bit. What I'm planning is go in the CME plane, come back. Get to the distal one. Now you can go. If at all if there is a difficulty, I mean overlay mode for me. You can see the nerves. Can you see? Nerves clearly here, posteriorly. Can you see the ureter nicely?
Yeah.
Yeah.
So here in this kind of tunnel, it's definitely useful. Sometimes even in the high definition camera, we find it difficult to, especially if it is covered with a thick mesentery, we might find it difficult to use. But here, even in a crevice, even deep inside the, tunnel, we can able to identify and then preserve the ureter. So I'm reasonably not worried because of the presence of the overlay. Come back. Because generally we take, especially in the air or elbow air, we go little higher, trace the ureter and then come. Here, one is I want to preserve the vascular pedicle. The other one is those areas are inflamed. So I now close. Okay. Can you see the ureter?
Yes. Yes. Yes.
Yeah.
Hello, Dr. Bhatta.
Yeah. There's a question from the audience.
Yeah.
Hi, Dr. Anil Uru here from Mumbai. Uh, so, just wanted to ask you the ureteric ICG. Do you use a ureteric catheter or do you keep the stent in situ?
No, we just use ureteric catheter. Okay.
Yeah, yeah.
We will inject, ICG about 2 cc, and then we remove the catheter at the end of the procedure.
So you keep it during the procedure. You keep the catheter.
The urethrium retains it for about 5 to 6 hours. So
So
throughout
yeah,
the end of the procedure, the entire procedure, it will be keeping on staying.
So we have been doing the same. We have been using it but we remove it the ureteric catheter as it remains for more than that. Usually it remains for a very long time. Yeah.
Now you can see the psoas muscle on the opposite side. The psoas muscle. Yeah.
Yes, we can appreciate that.
Yeah. Yeah, I will be. Ureter is on the floor. Closer. Can you see the ureter on the floor? This is coronal vessel and clean the camera. So now, normal mode. After placing a gauze space, I may go a little mobilize the lateral aspect and then come. Or gauze space. Yeah. இனிமே வந்து அந்த reusable கொடுக்குறீங்களா? அந்த எக்ஸல் ப்ரோக்கர் கொடுக்குறீங்களா? Yeah. Sorry. So what I am going to do is, this mode is called continuous autofocus mode by Olympus, so that I no need to focus every time. Come back. Go inside. It's a small window which I made, not enough. Closer. Go inside. But I'll make sure that this is above the urethra. Come back. As I told you, I may sacrifice the superior rectal artery if it is coming in our way, but nevertheless, as of now, I am planning to preserve it. This is an open God space, bigger one, which will have a longer length so that we can able to plug it inside. Yeah. Now we can leave the wooden. Now I'll go laterally. Yes, hold it like this. Harmonic. Even my harmonic may not reach to the opposite side because of obesity. Let me try. Otherwise, I will be using my left hand. I'm inside.
Are you using extra length instruments, the bariatric instruments for this case, or
No. As
ports
of now, no.
as of now?
But I may use. Here also my angle is not good. What? Uh, you concentrate. Yeah. Okay. அதுல இப்ப மாதிரி அந்த மாதிரி இருக்குது இல்ல ஹார்மோனிக். This is one of the sometimes area of uric injury. You see, laterally it is attached. I will go to that area later because I wanted to go from normal to the inflamed area. Okay?
Yeah.
Closer.
Dr. Sanil will just go to Coimbatore. Dr. Rajamandal is going to do the anastomosis.
Yeah, sure.
Rajamandal sir, we are with you.
Coimbatore team, sir. Hello.
Hello. Rajamandal sir. Hello.
Audio போதா இல்லையா?
Sir, are you audible?
Yeah, I'm hearing you. Can you hear me?
Yes, sir. Very well. So you are saying that you are going to do anastomosis now. What size stapler are you using, sir?
See, I'm using 29,
Okay.
29, Ethicon 29. Wait a minute. It is very low. Keep like that. கொஞ்சம் இந்த பக்கம் வா. அப்படியே இரு. அப்படியே அப்படியே இரு, அப்படியே இரு. நீ வந்து இந்த ரைட்டு நீ அப்படிதான் காமிக்கணும். It is a cola anal, so you have to see
Yeah,
the whole circle. Now you come open. Yes.
nice.
One side of the. Okay, good. கொஞ்சம் இந்த பக்கம் வச்சுக்கோ. Okay. Hey, come out, come out, come out, come out. கொஞ்சம் head up பண்ணிக்கோ. You can see already I have seen the pouch and everything is coming nicely.
Okay. Yeah, you verified that there's no twisting. How?
Yeah. No twisting. Okay. You can see nicely it is coming.
Yes.
இரு, இரு. Come here, come here. Here. Okay. Yeah, it is closed. Is it, go near. Yeah, அந்த வெளியே காமி man. So it is a motorized one.
Oh,
You can see there will be a go near, right. So you have to make there should not be anything should be not be in between the tissues.
yeah.
Unlock. Yes, close. See, while closing, he is closing very close, slowly. Okay, so that not any the bleeding will be less,
Yeah.
and the anastomosis will be nice. அப்படி நடத்துக்கும். Quite a large pouch only. Okay. Go near.
So make sure there is no intervening tissue in between the
Yes,
anastomosis.
yes. Huh? Yeah, wait for 1 minute, no problem. Always like routine. So wait for like 30 seconds or 1 minute. Usually wait for 1 minute, then fire. Okay. Yeah. You can see. You can see the sound.
Yes.
You can hear the sound. Now it's a green light. That means it's fired.
Okay.
So wait for another like 30 seconds. 30 seconds, wait for 30 seconds. Then you do suction. இது கொடு. எப்படி? Suction sound வந்துட்டு இருக்கு. Open suction. Yes, 7 mm பண்ண 5 mm போடுமா. Okay. Like a fistile you have to remove. But here hardly only 2 centimeters is there. So once you pull it will come out. Suction.
Hmm.
Sometimes while making the pouch, while putting the anvil inside,
Hmm.
sometimes if you don't tie it properly, so anvil can go inside the pouch and it will be very difficult after going in. Okay, so once it has happened, so that's why we put a stitch and we leave the stitch long, so that if anything, now we can pull the stitch and retrieve the anvil.
Okay.
Suck, suck, suck. We'll do a leak test. We'll see the donut. Then we'll keep a ileostomy and come out. Okay. Suck, suck, suck. Suck, suck, suck. Suck, suck, suck. We'll show the donut now.
Yeah.
Ah,
Yes, sir.
okay, it's okay. So it will be like that only because we are make from the apex of the pouch. Okay,
Okay.
okay. We'll do the air leak test. One minute, 1 minute. Head up கொஞ்சம் பண்ணுங்க. லேசா. போதும் போதும்.
The pouch looks definitely more than 15 centimeters, sir. Looks a bit
Yes.
redundant.
Okay. Put there. Okay. We have deflated the pouch. Yes. Suck, suck, suck. So air leak test. There's no obvious bubbles.
Yeah.
Suck, suck. So I am going to do a ileostomy now because all my TPC, IPA, I will make a pouch. Sorry, I will make a ileostomy, diversion ileostomy.
And when do you close it, sir?
40 centimeter. Yes, yes. I will be closing within 6 weeks.
Within six
Suck,
weeks.
suck, suck. Provided everything is okay, patient is not having any other problem. Okay. So I will be taking around 40 centimeter from the proximal part of the pouch. Bowl holding kudu.
Okay.
Head down பண்ணுங்க. Okay, thank you. I think
Thank you, sir. Thank you very much. It was a very fantastic uh, presentation and beautiful surgery, bloodless surgery. We all enjoyed it thoroughly, sir. Big round of applause for Dr. Raj Pandian.
oh,
Thank you,
thank you,
sir.
thank you. So you can go to the other
Chennai.
OT, yeah, Chennai OT. What is the time now?
Time is
1:30. Okay. So I will join for the lecture. Go kudu. Okay, thank you.
We'll move to Chennai units. Thank you, sir.
Okay, okay. Thank you very much for moderating.
Thank you, sir.
Hello.
Yes, sir. Chennai is on, sir.
Yeah.
Yeah,
Dr. Sandil, we are with you.
yeah. So I'll just show after this small suction teams recording. First question. So as I told you, this is the below is the superior rectal artery.
Yeah, able to see that.
So we are in the process of dividing. This is one of the sigmoidal branch. One of the sigmoidal branch that I'm going to apply clips because it looks slightly bigger, and you can see a vein, the sun the corresponding vein over there. Can you see?
Yeah.
So this is the autofocus mode. Sometimes you can have autofocus. So what I'm going to do is, this is, come back, yes. So this is the superior rectal artery, which is going down. Above which I'm going to divide all these. Okay?
Yeah.
The entire
In inflamed mesentery is definitely more difficult to figure out individual branches of sigmoid.
correct. One large stimulus may not be adequate. Closer. One more. I'll be using on the specimen side because I don't have much space here. For double security, I'll be using here. This is the sigmoid branch and the ligation segment. Here today I have the luxury of using both ligature and harmonic in tandem. Wherever I feel that they will be of use, I'm going to do that. Double flip, double fire. Ureter, again, now since we are doing this, I'll take the gauze strip to see the ureter. Go slow. So the ureter is down below, okay?
Able to see that, yeah.
We are safe. Now we have got some space to operate. Now we'll continue with this mesenterically.
Yeah.
ம் இப்போ வருதாடா கேட்குதா? இப்போ அந்த ஸ்லைட் ஷோ போகிறேன், ஸ்லைட் ஷோ மட்டும் இதாக தான் பாரு, ஃபுல் ஸ்க்ரீன் வந்துச்சு ஸ்லைட் ஷோ. ஸ்லைட் ஷோ ஃபுல் ஸ்க்ரீன் இருக்கா? இது ஸ்லைட் ஷோ ஃபுல் ஸ்க்ரீன் போட்டு வருதா? ஆ ஆமாம், அது சைடில் தானே வருது, சைடில் தானே வருது. ஆ இது வீடியோ ப்ளே பண்ணுற ஓகேவான்னு பாரு. கிளியராக இருக்கா? நின்று ப்ளே ஆகுதா? ஆமாம். அது கொஞ்சம் பேண்ட் பிடிச்சிட்டு அப்புறம் வருதுன்னு நினைக்கிறேன். ம் சரி ஓகே, நான் போய் இனிமேல் பிரசன்ட் பண்ண சொல்லிக்கிறேன். நான் போயிட்டு வந்துட்டா, நான் வெங்கடாஜன் சார் வீட்டுக்கு போயிட்டு வந்தேன். அதுக்கு இங்கே அவங்களும் கனெக்ட் பண்ணிட்டாங்க, இப்போயே கனெக்ட் பண்ணிட்டாங்க அவங்க. ஹலோ, ஆமாம் ஆமாங்க, அதே லிங்க் அதே லிங்க், நீங்கள் அதே இருந்துங்க, ஒன்றும் பிரச்சனை இல்லை. ஓகேங்க. எப்படிங்க? அதுக்கப்புறம் தான் 4:45 தான் சொன்னார். இன்னும் லேட் ஆகுமா அப்போ? ஓ சரி, லேட்டானா விடுங்க, அந்த செஷனில் தான் பண்ண முடியும். சரி, அப்புறம் அவர்கிட்ட சொல்லிடுறேன் விடுங்க. ஆ ஆ சரி ஓகே ஓகே. 1 ஹவர் டிலே போகுதா?
said that laparoscopic surgery was more effective than open surgery for colon cancer in terms of morbidity, hospital stay, tumor recurrence, and cancer-related survival. Immediately after that, lots of interest across Europe, UK, then the US, and then Asia. So lots of people started working on it. And then there was this cost trial, which came out in 2004, which this trial showed that it was a multi-institutional trial, showed the rates of recurrent cancer were similar after laparocolectomy, suggesting lapidable alternative. The classic trial, often quoted in 2005, which showed that lap surgery for cancer of the colon is as effective as open surgery in the short term and is likely to produce similar long-term outcomes. So similar results. But we all felt that lap surgery was, added advantage, quicker return to normalcy. So in 2005 was a color trial which showed that lap surgery can be used for safe and radical resection of cancer in the right, left, and sigmoid colon. And then in 2008 was the ALCAS trial, which showed that lap-assisted colonic resection gives significant improvements in return to GI function and length of stay with an increased operative time and no difference in post-operative complication rate. So that's when robotic surgery was evolving almost for a decade and a half now. So we know that robotic surgery is particularly useful in rectal cancer, colon cancer. Again, a lot of people don't see the benefit. In our program, we just use robotics for everything, just so that as a program, we want to be doing lots and lots of this so that we get efficient at it. As a team, we know how to use robotics and build on the program and volumes and numbers and hence outcomes. So particularly useful in rectal tumors. We know the advantages of robotics. I'm not going to go into it. There's one very popular rollout trial which looked at in rectal cancer, which did not really come blazing for robotics. So there was always skepticism for robotics for colorectal cancer surgery. So since then, there's a lot of evidence which has been accumulating for colon cancer. The learning curve for robotic surgery in colorectal cancer surgery, there was a systematic review done by Dr. Harriet's group, which showed that operating times for robotic surgery will be faster than laparoscopy when surgeons are inexperienced in both platforms. Basically saying that you don't have to be trained in laparoscopy to go to robotics. You can just pick up as you go. Then there was a nationwide cohort study published in 2021, robotic was right colectomy for colon cancer, which showed that in 4,000 patients, which showed that robotic approach was significant higher lymph node yield and a similar postoperative morbidity compared to a laparoscopic approach for right colon. And you'll see that same theme across over for almost a decade. Now, in this paper, published in Journal of Robotic Surgery by Irshad Sheikh's group from Ipswich, Norwich, I think Norwich, right? PK, Norwich, right? Yeah. Comparison of robotic and laparoscopic left-sided colorectal cancer resection. They showed that robotic surgery for left-sided colon resection showed equivalent oncological resection compared to lap and reduced length of stay and low rates of conversion to open surgery. Again, reduced rates of conversion to open is a theme you would see again consistent in the last decade. Then this paper in Journal of Robotic Surgery from Vincent Dobar's team from Washington looked at the effect of obesity on laparoscopic and robotic colorectal surgery outcomes, looking at the large NESQIP data across the US, and they showed that robotic colorectal surgery is associated with less conversion to open, shorter length of stay compared to lap. Risk of prolonged ILS is significantly reduced with robotic surgery. In this paper from Cleary, published in Surgical Endoscopy, looking at conversion of robotic and lap, conversion rates in robotic surgery are half of those in lap. The excess expenditures attributed to robotics are attenuated by the consideration of the cost of conversions. So conversion lap to open is about 15%. Robotic to open is about 7%. And that's again consistent across many papers in the last decade or so. This paper published in Endoscopy 2023, looking at clinical outcomes of elective robotic breast lap surgery for colon cancer, utilizing a large national database from Europe, showed that, sorry, this is from the US, showed that from 83,841 patients between 2012 and 20, showed similar outcomes to lap with robotics, no difference in mortality or overall complications. but anastomotic leak rates were higher after robotic left colectomies. In this systematic review and meta-analysis of lap versus robotic-assisted surgery for colon cancer, published in Cancer 2024, based on 50,000 plus patients from 21 studies, 21 plus percentage patients who underwent robotic colon cancer surgery and 78.25 laparoscopic. They showed that robotic colectomies had a longer operative time, short hospital stay. Laparoscopy had a higher conversion rate, anastomotic lead rate was similar, higher lymph node yield with robotic colectomies. Another paper published more recently in colorectal disease, robotic versus laparoscopic approach for left-sided colon cancer. It's a Danish study from their large database, which is a very, very good database between 2014 and 19, where they compared lap or robotic left-sided sigmoid dissections. 5,532 patients. They showed that robotic colectomies have lower conversion rates, higher lymph node yield. Oncological and post-op outcomes are very similar. In this paper published in 2022 in the Annals of Surgery, comparing intracorporeal versus extracorporeal anastomosis and robotic right colectomies in a multi-center triple-blind randomized trial, a small subset of patients, 89 only, randomized though, with the intention to treat. They didn't show any statistically significant difference in patient-reported recovery between the groups, post-op pain, nausea, time to ambulation, time to first passage of flatus, then to stay. Again, had no differences. Duration of time to create an anastomosis was significantly longer with intracorporeal and no significant differences in post-op recovery. So, key points are similar oncological outcomes with robotic colectomy compared to laparoscopic surgery, more expensive, long operative time, shorter length of stay, less conversion to open, as much as half compared to laparoscopy, higher lymph node yield. Then you would ask the question, is it all worth it? It's a difficult question to answer. I think if you're dabbling into it and you're going to do a few cases, I'm not sure if you have a big program and you have a team which is, wants to really get onto it and do all comers for colorectal surgery robotically, I think you should do it. And I think in 5 to 10 years' time, laparoscopy will be replaced by robotics. Basically, an extension of laparoscopy. It's going to be just advanced laparoscopy, according to me. And so I think getting onto the learning curve early rather than waiting for some more time would be a wise thing to do in my limited experience. Thank you.
Thank you, Dr. Munikrishna. Any questions?
It's an excellent presentation, sir. So the only, it's not a question, it's a comment. I think why we're not getting very evident results with these trials is because when we compare the numbers, there are huge numbers in the laparoscopy and very small number in the robotic, because laparoscopy has been there for quite some time now. And as the numbers grow in the robotic arm, then those, the negatives might, get converted into the positives in the robotic arm as well.
I agree. I think, like for example, rectal cancer, your TME is standardized, whether you do open, lap, or robotic. If it's standardized and you are well versed in it, your outcome should be similar. I think where the difference is going to be the short-term outcomes, maybe pain, maybe quicker recovery. I personally think that my mobilizations are even more better. Sometimes I wonder if I was doing it now. Just looking back, why is it? Maybe you're seeing things better with the better imaging and the articulation of the instruments, so you're able to, use the technology to look at different parts of the abdomen, make sure the mobilization is good. I think that's one of the key things, and you're right. And it's very difficult at this point in time to do a randomized trial. Very difficult, not like there's too many regulations. So you just have to go on observational data or our own data, which is laparoscopy, just compare it rather than. I don't think they have time to run randomized trial. It's going to be very good.
Yeah, another thing I feel in robotics, it's important in colonic surgery. I've seen in two areas it's very like in CME, the dissection definitely becomes much more meticulous around the vessels with the robot. That's much more easier. Plus intracorporeal anastomosis, you're much more comfortable doing an intra, and that ultimately results into a better outcome. So I think these are the two areas which definitely robotics.
Agrees. Yeah. Thank you. My observation, I've been in that open lab and now robotic era. I feel definitely the learning curve is not as much as it was in the lab period. And the next thing, what Madam was telling, yes, what during my talks, the laparoscopy, we used to talk always, we are comparing a century with that of a decade. That's what usually used to happen. Yes. The number of instruments, what is going to be available, is going to increase with a lot of other companies coming into work. And hence, maybe like lab has become the thing in every nook and corner of the country, or whatever you call it. Any hospital has that. That needs to happen. In few years, that will happen. That is when you will see the numbers. Yeah, the numbers are increasing because, see, bulk of whatever colorectal you are talking about, they're all happening in the peripheral centers where you don't have these facilities. So to get those numbers, it is going to take some time.
This year in the Society of Robotic Surgery meeting was honored at 83 new robots. 83. Different, all almost coming to FDA approval, Europe CE mark. So I think in the next 3-4 years, you'll see lots and lots of robots which are going to get cheaper, very competitive, and they will get to your operating rooms within 5 years for sure. Your labs, like the TV5, for example, I think surgery is going to be all about workflow. So basically, what they have is a console which is so easily maneuverable. They have a stack which has got a laparoscope in it. Apart from the robotic camera laparoscope in it, it's got insufflator, it's got smoke evacuator, it's got an edge device. Now, even better, all of them can be controlled from your console. So what that means is you don't have to ask anyone. You can increase your gas, suck your gas out, increase your color, whatnot, energy, everything. So workflow is going to be so smooth, and you're going to get more and more efficient. So, yeah, exciting time for that.
Thank you, Dr. Venkatesh. So we have the last speaker of the session, Dr. Chetan Kantaria. He will be speaking on the obstetric colon cancer. What do I do?
Respected chairpersons, seniors, colleagues, and friends, the topic of my today's discussion is the obstructive colon cancer. What do I do? So, obstructive colon cancer is not an uncommon problem. Around 10 to 18% of patients present of malignant CA colon present with obstruction. It's indeed a problem and challenge to the treating surgeons because these patients are usually in poor general condition. They are in state of catabolism with muscle wasting and poor oral intake. Many of them have concomitant spontaneous colonic perforation. They are usually in advanced stage of malignancy, and not very often they require immediate emergency intervention. So before we go on to what are the treatment options available, let us see that the colon cancer can be divided into right-sided obstruction and left-sided obstruction. And it's important to divide them because their presentation is different, their incidence is different, and their management varies. So right-sided obstruction is obstruction which occurs proximal to the splenic flexure. The incidence is low because the diameter of the right side colon is more, and therefore before the tumor becomes bulky and obstructive, they are usually picked up. However, they are more advanced locally. On the other hand, left-sided obstruction, the incidence is more comparatively because the lumen is smaller in diameter, so they tend to get obstructed early. But having said that, the rectum doesn't get obstructed very commonly because it gets picked up early because of its symptoms. And that is why it doesn't get obstructed more commonly than the left colon. So what are the treatment options available for right-sided cancer obstruction? So this includes primary oncological resection, may it be right hemicolectomy or extended right hemicolectomy with ileocholic anastomosis, creation of loop ileostomy after resection and anastomosis, creation of end ileostomy after resection only, creation of loop ileostomy without resection, and hydrocolloid bypass surgery, staged operation after the endoscopic placement of self-expanding metallic stent. So let us look briefly into each. As far as the primary oncologic resection is concerned, almost majority of the patients, they undergo emergency primary resection with ileocolic anastomosis being the preferred anastomotic choice. And this is because the blood supply is very good and you can manipulate the dilated proximal bowel loop very easily without much problem. However, it comes at a cost of increased post-operative morbidity, high anastomotic leak, and post-operative mortality when compared to elective primary resection surgery. So one needs to take a call which group of patients should be resected primarily and which should be done at a later stage. Now we come to loop ileostomy after resection and anastomosis. So this is indicated when patient has severe intraperitoneal contamination following perforation. So these patients, when you do a stoma, you have the complication of high output from the ileostomy with its consequent complication of dehydration, electrolyte imbalance, and acute renal failure. So one needs to actually balance between the risk of the anastomotic leakage and stoma-related morbidity before doing a ileostomy after doing a resection anastomosis. Then coming to creation of end ileostomy after resection only, meaning that you resect the pathology, but you don't do an anastomosis and you create an ileostomy. So this is done in patients who have unstable hemodynamic condition with severe intraperitoneal contamination following bowel perforation. But again, you have to take into the consideration the risk of high output ileostomy and its consequent complications. Then you just create a loop ileostomy or do an enterocolic bypass surgery. This is done when the pathology or the growth is stuck to the adjacent structure. You cannot do much rather than causing more harm. It is better to just do a bypass or do a loop ileostomy and at a later stage after downstaging do a definitive thing. Now coming to staged operation after endoscopic placement of SEMS. As shown in this meta-analysis, the technical success rate with this is as high as 96%. The post-operative complication ranges is low. A little better than the emergency surgery. So, if I have to summarize the management of the right-sided colonic obstruction, I would say that it depends upon whether there is concomitant presence of perforation and peritonitis and the hemodynamic stability of the patient, which is going to determine what option will you practice. Though at present times, primary oncological resection seems to be the preferred treatment, though a large size prospective comparative study is required to give a concrete evidence with regards to this. Now coming to left-sided obstruction, the treatment options are comparatively controversial, not straightforward as compared to the right. The options include primary tumor resection with end stoma formation. This is a conventional and preferred treatment in emergency, which most of us follow. Next is diverting stoma, followed by primary resection and anastomosis. This is done in a select subgroup of patients who have no other complications and no risk of for anastomotic leakage. And finally, endoscopic stent placement followed by state surgery. So as far as primary tumor resection with end stoma is concerned, though it appears to be very attractive option, it is important to note that almost around 70% of patients, they end up with permanent stoma after emergency surgery because for some or the other reason, they don't undergo subsequent stage of surgeries. Besides this, the subsequent stoma reversal also is associated with high morbidity rate of as high as 20 to 35%. So though this option appears to be safe, this two-stage surgery is complex and it affects the quality of life significantly. Diverting stomas, the advantages is that it stabilizes the patient's general condition, gives you time to stage properly and plan the resection. However, if you take the cumulative morbidity and mortality of each stage involved, then it has no advantage over the stage procedure. Besides this, one also needs to take into consideration that at each stage you will get certain percentage of patients dropping out without going the subsequent stage. Now, primary resection and anastomosis is again practiced in a select subgroup of patients who have no other complications. However, it should not be done in patients with advanced stage, comorbidities, advanced tumor stage, malnutrition, and presence of peritoneal contamination. And finally, coming to placement of SEMS followed by stage surgery. So this is a bridge to surgery in resectable disease in emergency. It has its advantage of decreased morbidity, improved quality of life, shorter hospital stay, shorter intensive care unit stay, fewer surgical procedures, and reduced medical costs. So as per the latest systematic review shown, which included 7 different randomized control trials, the success rate is very high. The permanent stoma rate is low. The primary anastomotic rate is also high. The overall mortality rate is only 11%. And they concluded the location and length of the obstructing cancer lesion influences the success of outcome as well as the technical placement of the stent. However, they found no difference in post-operative morbidity, mortality, and stoma formation compared to emergency surgery. So these are the recent studies which have been carried over the last few years. So what they have concluded is that the 3-year overall survival and disease-free survival were not different between the SEMS group and the emergency stage group. Besides this, you have to also take into consideration that SEMS has its own set of complications, including colonic perforation, stent migration, failure to expand within the lumen, bleeding, subsequent reobstruction, and most important, which we tend to ignore, is that there occurs stent-induced tumor manipulation with increasing in the circulating tumor DNA concentration. So I would like to end by summarizing that as far as the treatment for obstructed colonic cancer is concerned, it is individualized. You cannot say that one size fits for all. The decision is essentially based upon the patient's index presentation, the general condition of the patient, associated comorbidities, risk factors which may affect the short-term outcome, and you have to select the option which gives you the best oncological response. Thank you very much.
Nice talk indeed. So I just have just a discussion. What you presented is regarding the reversal of Hartmann. So the rates are very high as per the literature. So around 30 to 40% of the patients, they don't undergo reversal. But this data is from the diverticulitis.
No, this is
for colonic cancer. What we feel, our rates, what I feel, though there are no publications, our rates are not that high for not doing the Hartmann reversal. So rectal cancer, sigmoid cancers presenting to us in an emergency, performing in Hartmann's, most of the times we are able to do the reversal. But what is the literature quotes is mostly from the diverticulitis
I will tell you. No,
data.
This data is from the oncological group data. I have given the references. One. Second is the reason for not going into subsequent stage is we are talking of colonic resection. Is that these patients, certain subgroup of patients will undergo adjuvant therapy. Of this, there are going to be certain fallouts. Then there are going to be certain people who are going to be non-responders, elderly patients, lost to follow. So as high as around 50 to 60%, this is our experience. I work in a public hospital. This has been our experience that not 100% of patients come for stoma reversal closure at a later date.
Can I add something here?
Yeah,
sir?
please.
I think somewhere along the line, we as surgeons, we somehow kind of swing as a pendulum between optimism and skepticism. And so two positive results. So this is more in context of emergency surgery for obstructing colon cancer. When we look at that systematic meta-analysis, systematic review, everything, it says that you can do this, you can do that. But at the end of the day, that significant majority of the patients who finally end up with an obstructed colonic cancer would be patients who would have significant comorbidities. As time will increase, we have an aging population with more and more comorbidities. We'll also have these patients who have relatively lesser access to healthcare, and so the general condition is also bound to be poorer. So it is going to be more and more about being very, very careful. If you have a patient in whom obstruction as a risk factor for an anastomotic leak exists, pretty sure a lot of other risk factors would be there. These patients would have a borderline hemoglobin, uncontrolled comorbidities, poor general condition, poor performance.
So
It was
that
all
was
put in
that,
together.
that was my first slide.
Yes,
That is
absolutely.
the problem.
That is the problem.
Now, what actually we do in practice, now in a public hospital, what we do in practice, if it is a right-sided obstruction, if it is resectable, you go ahead, resect it. You either do a primary anastomosis if the patient is young and there is no perforation, or you do a anastomosis and you do a proximal diverting stone. Period. For the left-sided, what do you do? If the left-sided obstruction is there and you want to you want to give a neoadjuvant setting in the lower sigmoid colon, if there is, you find that there is serosal involvement and you want to give neoadjuvant, you would do again a diverting proximal stoma, give a chemotherapy, take up the patient at a later stage, either following chemotherapy, or you don't want to give a chemotherapy, you build up the patient, take up the patient for a stage. But in that also, as he rightly said, that there are certain group of patients who are elderly. They said, we don't want to do much. We are happy with this stoma. It's working well. We'll see that. So that is the reason why they don't come up for subsequent. There is fallout in each particular group. This is the standard thing. Now with availability of SEMS, now the problem with SEMS is what? That you cannot anchor it properly. It slips, it migrates. So that is the problem. That is why many of those SEMS sounds very attractive. You always do a proximal diverting stoma and then you do a definitive
So
surgery.
one thing about SEMS also, SEMS is a very good bridge to surgery.
Exactly.
But when you are using it to bridge a time where the patient also has to get neoadjuvant therapy, that is where it creates more problems.
SEMS
And
actually,
even when it bridges to surgery, there are challenges.
SEMS is a very good option for rectal tumors rather than the left-sided colonic tumors, because the anchoring is a problem in the left-sided colon. Rectum, you can still anchor it well.
The rectum, the problem with the SEMS is the radiation subsequently.
Radiation, yes.
Your tumor volume and the
Because
GTV that they
NCRT will
calculate, it ends up irradiating a lot of stuff, becomes really impossible to get the small ball away from
actually, we tend to underestimate the complication of circulating tumor DNA, which is a very, very important thing. I think sir will be able to tell more on it.
Sir, one question, sir. Sir, I'm a student. Sir, I want to ask that in your experience, what is your anastomotic leak rate in obstructed patient when you do the primary dissection and anastomosis as compared to when you do stoma followed by anastomosis?
So as I said, there are various variables which you have to take into account. No, I'm telling you, various variables which will determine your leak rate. One is the age of the patient. Second is this obstructed tumor perforated or not? What is if there is contamination or not? Then third is whether there are associated comorbidities, in the sense that whether they have got atherosclerosis with poor blood supply. So these are all factors which take. But if you ask me, in ours, for the right-sided colonic malignancy, the leak rate will be around 10%.
So in those who had
So in those
stoma
patients,
followed by
we will not do a primary anastomosis. We'll be prudent enough to do only resection and bring out a stoma and do at a later stage. Thank you, Dr. Deepak.
Just a comment actually. For obstructed patients or partially obstructed colonic cancers, and we do a left-sided anastomosis after resection. Ideally, I think it's important that you do a transverse colostomy as a diversion rather than an ileostomy, because ileostomy a lot of times is not able to decompress the obstructed colon. I think that's a mistake.
It will kind of make you like very difficult to do minimal access later. The minimal access later, it becomes much more difficult. You have to take down the stoma and bring it back up.
Just a comment and the discussion. Once it is obstructed, it is always messy.
It's always messy.
So what we do, we get a sleeve, camera cover, put it in the colon and
pull it up.
That way, you cannot contaminate some soil.
Sir, case of CA sigmoid obstructive causing a closed loop obstruction and almost causing the transparent necrosis of the transverse colon, almost patchy necrosis of the entire colon. What would be the best procedure? Because it was causing the necrosis till the ascending colon.
So you will resect it,
yes,
and bring it out as a stoma and anastomose at a later date.
So the entire colon was necrotic.
So you have to resect the entire colon along the pathology.
I think that's a very valid point that you brought forth. So sometimes you'll have patients who've had a left-sided obstruction for a long period of time, and you thought that this was probably an uncomplicated obstruction. But then in some of these patients, we started doing trying to do some bit of even when we planned just a transverse colostomy, to do some form of a limited laparoscopy, just to be sure that the right side of the colon is not necrosed. Because sometimes you can have patchy ischemic necrosis only of the cecum. And that
this is not uncommon. Very
this is
commonly
yes.
seen.
So this situation that you have pointed out is extremely important to know, and you have to know that you have to do the entire colon has to be dissected, and you'll have to bring in an endostomy at the end of the day.
What was the actual question? See, if it is necrosis, you need to remove it.
This is what he was asking.
Because of left-sided colon, he was
What I had a patient, so she was very bad. She was having metabolic acidosis. That's why you're asking. So when I was resecting, then I was seeing the patches, and the entire colon was not at all bleeding, and the surgery time was increasing. So if the patient in a damage control surgery, should we take a risk of doing a total colectomy, or can we take a risk?
You know what? Doing total colectomy in such patients is much easier because there is loss of blood supply. You can just remove it very easily.
Actually, you're doing a very safe procedure. Safety is priority. Okay. You try to do the total colectomy. Whatever the area is normal, you try to bring it out, and then we'll escape.
Because if you leave behind, the patient is going to give you more problems post-operation.
You will not be peaceful.
And the patient will also not survive.
We had a wonderful session this time. Now we'll have further debates outside.
And messy is messy.
So we hand over to the chairperson of the next session, and that will be on rectal cancers. So Dr. Parvez Sheikh, Dr. Pawan Sugur, Dr. Suresh Kumar, Dr. Varghese Mathai, Dr. Subaiya. Kindly chair the session.
I have a dog.
Okay, we'll start the session. We'll have Dr. Rajpandian first because he's got a flight to catch. But yeah.
Okay.
Online. Yes, sir. Sorry, go ahead, Raj.
Good evening, everybody. Yeah. Can you see my slide?
Dr. Rajavan, sir?
Yeah, can you see my slide? Or
Yes,
you
sir,
see my
please.
slide?
Yes, sir.
In the screen?
Yes, sir. Yes, sir.
Okay. Thank you for allowing me to present as a first because I have to catch the flight to come there. So after finishing my live, so my talk is intersphincteric resection. Is it for all ultra low rectal cancer? So this is the topic given to me. So I am just going to talk about the intersphincteric dissection. So what is before going that we'll just have a definition of what is low rectal tumor and what is ultra low. Low rectal means less than 5 centimeters from anal verge, and ultra low means 1 centimeter from anorectal ring, or 3 centimeter from anal verge, or 1.5 centimeter from the dentate end. What I have shown this like within 2 centimeter from the dentate line. So what is the background of this ISR? So initially during Miles 1908. So they were thinking that is the rectal tumor is spreading through cylindrical and going towards downward spread. So later it was proven wrong, and now the upward spread concept has occurred, and over a period of combined neoadjuvant chemoradiotherapy, distal resection margin right from the 5 centimeter, then 2 centimeter, and less than 1 centimeter, even if a frozen section is negative. Now it has become standard even to do an intersphincteric resection with the preserving, that is sphincter preserving with good quality of life. So you can avoid a majority APR. So with this over a past like 2 decades, probably after 2010, for example, APR 60% APR, more than 75% has been turned into intersphincteric resection for ultra lower because of the distal dissection margin as less than a centimeter or less than even 5 mm. So this is the when during 1960s, 90s, and 2010 afterwards, the intersphincter resection, even within 1 centimeter from a dentate line, you can preserve the sphincter. So who invented actually, it was by the Rodolphe Sichel. So he is the one who adapted this intersphincter resection, and he did in 1984. But he has to wait for 10 years to produce his paper in 1994. And he coined the definition of intersphincter resection. It is a transanal division of the rectum with removal of part or entire internal anal sphincter after a good TME, thus obtaining an adequate distal margin. Restoration of the bowel content is achieved by performing a hand-sewn colon anastomosis. So this is the definition given by him. But of course, in all low rectal cancer, you do not have an intersphincter resection. In a good female patient, even you can do ultralow anti-resection channel using a stapler. So these are the various types. Type 1, type 2, and type 3 will have ISR. Of course, type 4 involving the external sphincter and internal sphincter, more you go for APR. So these are surgical options available for low rectal or ultra rectal tumors. So you can have a stapler anastomosis or ISR or you have a APR. So the common indication, as I told, all the indication for ultra low tumors. But the important things, the local spread is restricted to the rectal wall or upper part of the internal anal sphincter. There should not be external anal sphincter. An adequate preoperative sphincter function and continence should be objectively measured, and absence of distal metastasis. Contraindication present for fecal incontinence, old page. If the incontinence is there, you should not go for ISR. So selection of patients is very important and undifferentiated. Before doing that, just we want to have a brush up or anatomical knowledge. The internal anal sphincter is nothing but the distal condensation of circle muscle layer of the rectum, and external anal sphincter, the deeper part of the external anal sphincter, will be merged with the levator muscles. These are things we should keep in mind, so that we will know the clarity of the various types of intersphincter dissection. You have a partial, you can see A, B, C. This A is partial, B is subtotal, and C is total. So we never do ISR because it will be like the quality of life will be much worse when compared to A and B. So majority, whatever we are doing in like nearly 200 cases, mostly like 90% will be partial intersphincter resection, and few like 10% will be subtotal. I never do a total ISR. So coming to the surgical technique, so ISR colon anastomosis performed actually for like any other cases, you do a proper TME, whether you do laparoscopy or robotic or even open method. Then once the abdominal part is over, then you go up to the pelvic floor, and dissection can be done laparoscopically or robotically in the intersphincteric vein, the transabdominal part itself. So that is the very key. So how to do that? Once I'll be showing in a few minutes of video. So that posteriorly first go to the intersphincteric dissection and come laterally, then come to the anterior. The dissection is done as distal as possible up to the pelvic floor, and the puborectalis muscle surrounding the lateral and posterior wall of the rectum is exposed to facilitate the perineal dissection. So if you do a nice transabdominal laparoscopic TME, even beyond the pelvic floor in the intersphincteric plane, the perineal part will be very easy. The important thing is you need a self-retaining retractor, and position of the patient will be according to whether it is anterior tumor prone jerks or posterior tumor lithotomy. But for all type of tumors, because all the patients will have a neoadjuvant CTRT, so I do only the lithotomy. We need not have a prone jerks. I'll be showing, this is the perineal. You can see it is around hardly 2 centimeter from the dentate line, 1.52 centimeter you can see there. So you give 1 centimeter clearance and mark, and you have to, I used to close the 10 prolin so that the rectal lumen is closed. Then after that 0.5 centimeter distal root will make an incision, full thickness, that is including the internal sphincter, and the specimen is delivered out, then sutured. So what can, as I told, the coloanal anastomosis can be done by, particularly in a female, even just above or at the just above the dentate line, you can use a stapler anastomosis, even in the ultra low, maybe.
We have lost the reception, I guess. Dr. Raj Pandian. Yeah.
என்ன ஸ்லைட்ல இருந்து போச்சுங்க?
How do we achieve this?
Hello?
This is what I do.
Go ahead.
Yeah, is okay. Yeah, the reducing the toxicity and avoiding the over treatment of these patients, will be able to give a good quality of life to these patients. That is what we are trying to do. And the rationale for staging rectal cancer, the most important thing why we stage this rectal cancer is to identify the high-risk patients so that they will be benefiting from that of neoadjuvant treatment, and we'll also have some amount of anatomic information where we'll be able to do our planning of surgery better. And most important again is risk stratification using the prognostic factors. What is that is important? Staging is both local and distant metastatic staging workup. We should not forget that a good clinical examination might pick up a supraclavicular node or an inguinal node, which can stage the patient clinically itself. And also, it's important that we identify any obstructive lesions, whether of abdominal distension or whether of perirectal examination. Whatever I've mentioned, these investigation modalities are very important for staging. Each has its own advantage and disadvantage. When you talk about the endorectal ultrasound, it has its own advantage of T1, T2, N0, N12. But for rectal cancer staging, a gold standard we all know is only that of a MRI. Right. Staging is usually the AJCC TNM staging is what is going to be used for the rectal cancer. The most important thing, what I want us, the crowd, to understand here is, here we are asking only about the pre-operative staging. That is, routinely the TNM has something called as the specimen will be there in the post-operative period. That specimen will be assessed for that other T status, N status. Here we are talking about the pre-operative assessment of the T status. And this has been very well validated by many number of studies wherein they have shown that if a properly done MRI's results are there and they are compared with that of the histopathology, they are almost equivalent in terms of the spread, that's a T status. Apart from that, they have also experimented, they have also proved that the overall survival long-term results are almost the same. So the thing has come out that MRI is the gold standard for local imaging of rectal cancer. These are the various things we talk about: the T status, the regional lymph nodes, the M status. Before taking up the patient for any of the treatment, all these three sites need to be assessed so that we have a proper information, and then we decide on the treatment for rectal cancer. So these are the various prognostic factors which are going to be the indicators with which we are going to assess the staging of these patients. So we talk about the depth of tumor invasion, that is the extramural extension, the nodal status, the node deposits, extramural vascular invasion, the circumferential resection margin, the presence of any peritoneal perforation. All these things have they have been helpful for stratification using that of an MRI. So MRI will be able to get all the information and then we'll be able to stratify patients. What is that importance? What is the importance? So we will be able to subject these patients for proper. So these patients can be, we'll be having the proper stratification and they can be presented in the tumor board and we'll be able to take a proper decision. So if we talk about the depth of tumor spread, this is an independent prognostic factor, the information of which can be got in an MRI very adequately, wherein studies have shown if the infiltration is going to be more than 5 millimeter from that of the tumor, and that is muscular dystrophy extension more than 5 millimeter, then prognosis is poor in these patients. So same way, we were having a discussion, that wherein about 80% of the patients what we see in our clinical practice is going to be T3, and this is very important. More than differentiation between T2 and T3. Within T3, we have a lot of difference in survival. That heterogeneity needs to be addressed because lesions which are going to be less than 5 millimeter have a better prognosis when compared to the lesions which are more than 5 millimeter. And that can be easily assessed using that of the MRI, and that becomes important in the treatment because these patients are usually associated with that of extramural vascular invasion. Number of nodes are also going to be high in these patients, and these patients will definitely need some form of a neoadjuvant therapy before they are taken up for any treatment. Like the nodal status, again, it's an independent prognostic factor. More than 4 nodes is what is important. Wherein patients, if they're going to have more than 4 nodes, they generally have a lot of spread in that of the extramural area. The vascular invasion will be there, and the patients might have some CRM positivity also. So again, these are the patients who need some form of a neoadjuvant treatment. So identification of lateral nodes also becomes important when we evaluate these patients with rectal cancer. So the reason being, these patients will definitely need some form of treatment before they are taken up for surgery. All these, whatever we are talking about, is a pre-operative scenario, so we'll be able to assess the patient's exact status before we subject them for any particular treatment. And sometimes the lymph nodes may be adjacent to that of the mesorectal fascia. That can also be picked up by the evaluation when we are doing the MRI. And tumor deposit, this is something different from that of the lymph node metastasis. It is separate from that of the primary tumor, and it is a poor prognostic factor. Again, when these cases or when these tumor deposits are seen, these patients might also have other bad factors. They will need adjuvant treatment, neoadjuvant treatment. Extramural vascular invasion, it is nothing but a tumor present inside of the blood vessels. It is a very poor prognostic factor. It reduces the overall survival. The chance of local recurrence, distal metastasis is also very high, and there's a very good predictor for that of a hematogenous spread. And these patients, the patients with that of the extramural vascular invasion, the only best investigation available is that of an MRI, and these patients need to be treated before they are taken up for surgical procedure. Circumferential resection margin is the status of that of the mesorectal fascia, and positive is if it is less than 1 millimeter, there's a positivity. And this again needs treatment. These patients can be identified before that of surgery and they can be treated. Peritoneal involvement is a very good indicator that the patient might have that of the peritoneal surface failure or local recurrences. So MRI for rectal cancer, low rectal cancer, is staging on its own. Stage 3 and stage 4 are poor prognosticators. Why is it very important? We'll be able to strategize these patients for neoadjuvant treatment, or for that of achieving that of R0 resection, we need to take up this patient for extralevators, APRs. So on the whole, a good prognosticate the patients with that of a low risk or potentially a negative CRM, absence of extramural vascular invasion, T1, T2, and T3A and B, N0, N1 tumors. And opposite to this is the high-risk patient would be very important. These patients positive potential CRM, a committed interstitial space, T4 lesions, T3C and D, and extramural vascular invasion, and any N2 stages. These patients do have the risk of developing synchronous metastatic disease. So based on this, we strategize the patient into a low risk, intermediate risk, and high risk patient. Except for that of the low risk patients or the other intermediate and high risk patients, they do need neoadjuvant treatment. So this slide is very important. I will finish off because I do have some slides to be complete, but this is a very important slide wherein we'll be able to treat patients based on their recurrence pattern. So if patients who are going to have the EMBA positive, tumor deposits, N2 disease, T4 disease, elevated CEA, they have high chances of distant metastasis. So systemic therapy becomes very important before you take up these patients for surgery. So treatment or the evaluation of rectal cancer is very important. Likewise, for pelvic recurrence, local recurrences, patients with that of MRF positive, there's going to be a potential positivity for your circumferential resection margin. These patients need to be treated adequately before surgical intervention. Yes, evaluation for patients after that of neoadjuvant treatment is important, and that evaluation needs to be compared with that of the pre-operative, pre-neoadjuvant investigation, so that all those factors which have been used before should be used for comparison now, and then we need to see whether the assessment is proper or not. So they have their own tumor regression grade. And how is it going to be helpful? It allows us to plan our surgery, sphincter preservation possibility, surgery for deferral, and patients who are responded very well, organ preservation can be done for those patients. Recurrent tumors, they need to be staged. The reason they need to be staged is we need to achieve R0 resection in these patients. Done, sir.
Thank you very much. Any questions from the postgraduates? We have quite a few of them. So if there are no questions, I will ask you for the benefit of postgraduates. One is that following your neoadjuvant therapy, there occurs downsizing of the tumor. So which tumor margin will you take, the previous tumor margin or the current tumor margin into the treatment? So this is a very commonly asked question in exams. So that is why.
Rectal cancer, what we are seeing now is they respond amazingly to all the neoadjuvants. And we do have our own observation study wherein wait and watch is happening, and we have a huge number on that. So presenting our all India data also. Next week. A very good thing. Patients should not be taken up for surgery directly. Please subject them for neoadjuvant.
Excellent presentation. A very quick question. You are having lateral nodes present, right? So you're giving a TNT or CRT. There is partial response in the primary, but the iliac
What do
nodes
you
are.
mean by partial response of primary?
Yeah. So complete clinical response of the pelvic nodes. So if you operate for the primary, what will you do to the iliac nodes? You address, you don't address.
That is what the whole thing is about, staging. So you need to check whether the nodes are going to be positive and how they appear on your MRI. So have a good discussion with your radiologist, check whether the node size is reduced, the metabolic activity is there, and then take an assessment on
They
that.
say a complete clinical response, complete radiological response.
Then I will not text them. I will not text them. I'll go for the, if you're going to talk about the rectum per se, there's only a partial response. Those patients also, we give them some time and then reassess. So usually now the assessment is 8 months, 8 weeks, 10 weeks. We just go for 16
Another
weeks and then see that.
another common. Yeah, Anil.
If they have responded below 7 millimeters, we took 7 millimeters as the cutoff. Right? But they don't, they are not
The operator and internal AI both have, as Anil is putting out, they have different criteria. And 4 and 7 millimeters.
Another common scenario is post neoadjuvant. There is a good response, downsizing, but the CAA level persists to be high. What will be your approach?
I'll do a proper metastatic workup. Check out on the other organs and check whether the patient is a diabetic also. Many times we have had this scenario where the patient will have other comorbidities which can cause rise in CEA. CEA is not going to be the only thing. Actually check it with what is happening before you started the treatment. During the neoadjuvant, we see a lot of patients going in for diabetes and other things because of stress, and these things go up. So evaluate them properly, caution the patient, talk to the patient about all these things.
And in spite of it, you will go ahead and resect after counseling the patient.
Yeah, if on a proper evaluation you don't find any other metastatic disease, we go ahead for the primary if need.
If there is no response to the primary tumor and lateral nodes even after giving neoadjuvant therapy, how much time should we wait or should we continue?
See, this is exactly non-responder. Non-responder is, there are 2 options available. You go for change of therapies. If not, option is go ahead and operate on these kids. That reason why we operate. The patient's morbidity, if you don't operate on them, is going to be very bad. And there are 2 different school of thoughts. You just leave the patient alone. And some of us, we go ahead because we don't have other options. So as of today, check on the molecular status of the patient. Don't forget, things are coming up in a very nice way. Checkpoint inhibitors are there. And all you want, what you know, if it is going to be DMMR, you will be benefited with the whole thing. And check on other things also, BRAF and all those things. That may help you a lot.
One last question for the again postgraduates. Short-term radiotherapy, which subgroup of patients would you give? What are the drawbacks? And when will you take up the patient for surgery?
E3 disease. E3 disease is the one which is going to. Yes, sir. One talk is coming up. Yeah.
Okay. Thanks.
You'll be talking here? No, I'll not talk with you. Or they'll get bored.
Yeah. Thank you. Do we have Raj Pandyan online so that we can go back to it?
Hello, sir.
Hello?
Rajavan, sir, you are on, sir.
Okay. Sorry for the interruption. So I can join the good discussion. So am I audible?
Yeah, you're audible. Go ahead.
Please, in between, please, somebody communicate with this because almost I finished my talk previously. Okay, I hope the people have seen the previous slide. They said this is the last slide they have seen. So this is the type of ISR what is available. That is partial and total. So 90% of my ISR, which I have done nearly now 200, nearing 200. So 90% is only partial ISR. Of course, 10% is subtotal, but we never do a total ISR, which is the quality of life we can't bring in the total ISR. So the surgical technique is you do TME, whether you do a robotic, then go pelvic floor and dissect the interspinning plane. One start posteriorly and laterally as well, so that it will be easy when you are coming to the perineal part. So perineal part, you need a self-retained retractor and position of the patient usually with the lithotomy position. And this is the way I used to do you can see the lesion just around 2 centimeters from the dentate line, 1.5 to 2 centimeters. So they give a 0.5 to 1 centimeter. We suture the rectal lumen with 10 proline. Then 0.5 centimeter distal to it, we have a full thickness, that is full thickness dissection along with the internal sphincter. Then specimen is out and removed. And so as for lower cancer, you can have a stable anastomose, particularly in a female thin patient. You can even dissect from above. You can put a stapler colon anastomosis is also possible in case where the 3 centimeter from the verge patients, tumor. So this is important, but all the gadgets are there while you are operating. So you need a on-table sigmoidoscopy to assess the lower body. You have to make at least 1 centimeter distal clearance while the stapler. I will be having a special rectal clamp, that is a vascular clamp. Using the sigmoidoscopy, we will assess the lower distal margin of the tumor. After doing the proper TME, you go up to the pelvic floor. You can even dissect in between the muscle, that is in between the external sphincter and the levator. So on-table sigmoidoscopy I'm just doing. This is the vascular clamp. We used to say it's a rectal clamp. After giving the distal clearance, again we are seeing through the sigmoidoscopy. Then we are applying the stapler. So this is the dissection. Once you dissect, you can see it is at the pelvic floor. So now you, after splenic flexor mobilization, remove the specimen through the financial incision. Anvil is introduced. Then the stapler anastomosis is done. So this is another case where you can do laparoscopically the intersphincter from above, that is transabdominally. Another female patient. So dissection is taken care of. All this my intersphincter section will be neoadjuvant CTRT. Post neoadjuvant CTRT, there will be a lot of interstitial fluid will be there. You should maintain the layers. So you have to maintain the rectovaginal septum. So without injuring the posterior vaginal wall, you have to do the dissection. So the intersphincter dissection, you can see posteriorly go up to the pelvic floor. Once you see the pelvic floor, you can divide in between the layers, that is intersphincter dissection. So as I told, the internal sphincter is nothing but the combination of surface. Functional fibers will be collided along with the deeper part of the external sphincter. So almost we are in the pelvic floor. So now you go to the posterior part. The left lateral part we are going to the. So this is the intersphincteric plane. Lateral part. We are going in between the levator and the. This is the posterior part. Posteriorly, as much as possible, your perineum will be easy, difficult. So this part, intersphincteric dissection should be done laparoscopically as maximum as possible. So once you do the intersphincteric plane above, so through the perineal part will be easy. So this is the perineal part. So you mark the lower border of the lesion 1 centimeter distal the diathermy, then you use a 10 proline, full thickness bite. Then after that you give like 0.5 centimeter, then you make the internal sphincter, full thickness. So while making that, you should not damage the levator ani muscle, so that the quality of that post-operative Elias syndrome will be less. So you can use just a saline injection to elevate the submucosa so that the incision will be deeper. The specimen is out. So posteriorly, then laterally, the specimen will be out. And IMA pedicle. Divide, make sure the proximal colon has a very good blood supply, and make the suture along, including the sphincter. So use 6 o'clock, 3 o'clock, 9 o'clock, 12 o'clock, and in between you use 0 PDS, like a full thickness. So you can see the specimen, you have more than a centimeter, one clearance is. So when you compare the intersphincter resection versus APR, because most of the patient studies are APR, now this report there is a low local recurrence and better compared to APR, and the studies that is nearly 30% patients improve psychologically after surgery of the ISR. 23% experience no change in psychological symptoms. There is higher levels of psychological distress and more restriction in their level of social and sexual functioning. And the Conans et al. He has done the quality comparing LAR, ISR, and APR, and score and ERT6, that is global, and all are comparable between each other. the physical and sections were significantly better after ISR compared with the APR, but diarrhea and constipations were higher after ISR. But 90% of the patients responded that they never would have preferred to have a colostomy. This was the study. This shows. Although it is clear that patients after rectal cancer surgery will never have the same bowel function that they enjoyed before developing the rectal cancer, data support that intersphincter resection patients develop a new bowel function, which, although not perfect, is one that they are very pleased with and prefer over a permanent colostomy. However, the patient selection is very important. So with it, I would like to conclude that we have to individualize the treatment plan for patients with ultra-low rectal cancer. ISR is a valuable alternative to APR in selected patients, and ISR is oncologically safe with better quality of life over a period of time. Thank you for listening.
Thank you very much, Dr. Raj Pandian, for such an excellent talk and demonstration of video. I think the audience are all spellbound by the video. If there are no questions, we move on to the next speaker. The next speaker is Dr. S. Suresh.
Good evening. Thank you. I thank Dr. Ayyappan for making my speech easy, and I'm the odd man now. So today I'll be speaking of neoadjuvant treatment. My topic was the confusing conundrums, but it's been made that there's no confusing. So it is only a neoadjuvant treatment where in a certain group of patients where the bad and ugly, the good patients doesn't need a neoadjuvant, the bad and ugly will need a neoadjuvant. So the rationale for neoadjuvant, yes, because it has been already developed in many GI cancers, especially in stomach cancers and esophageal cancers. So, and then there's a better treatment compliance, and the treatment without delay can take care of the potential micrometastasis, and the tumor shrinkage could allow for a better resectability of the tumor. And also there is a possibility of evaluating the tumor for chemosensitivity, and can depend on adapting for adjuvant chemotherapy. And also there is a time for rehabilitation of the surgery. And against this, we delay the time for surgery, which is the definitive mode of treatment, and there will be risk progression. And risk of bowel obstruction and exposure to chemotherapy means there's a chemotherapy-induced toxicities. And so what is the whole issue and why should we think about neoadjuvant treatment is more important, and especially the need of the hour in the ugly patient, bad and ugly group of patients. Yes, because we have treatment objectives have changed. Organ preservation is the new prospective evaluated endpoint. And as we said, molecular stratification has been coming up, and MRI staging is more important. And patients who have undergone a surgery suffer a lot from pelvic surgery, which is an issue, and some patients can be stopped from preventing going ahead with surgery. So rectal cancers has been treated with either TME with or without neoadjuvant treatment. And coming to neoadjuvant treatment, we either have chemotherapy with or without addition of radiation. And the short course radiation, which we have been saying, and it has got a very good pathological response of around 11%. But we are moving ahead from that, and then we have the immunotherapy, and we can know that the recommendations have been changing. And this is a explore rectal guidelines, which Sarah has already elaborated in detail where to go with the surgery or when to go for neoadjuvant chemo. Now, the recommendation is whenever you have a biopsy from rectal cancers and there is a stage 3 or stage 2 or above, we need to always check for MSI and MMR. If the patient has got a deficient MMR and MSI high, then these are the patients who are going to benefit with dostarlimab. And we give 500 milligram IV once every 3 weeks for 6 months. That's